avoiding testing, avoiding the issue of prostate cancer puts them in a worse position. It leaves them with fewer options. We understand the disease better now. Not everybody needs their prostate removed, but those who have cancers that are potentially harmful, we want to find them as early as we can and treat them.
Welcome to 20-Minute Health Talk. I'm your host, Sandra Lindsay. For generations, prostate cancer carried a heavy weight, a diagnosis men often feared, expecting difficult treatments, and a steep decline in quality of life. But as Dr. Taneja now says, it's not your father's prostate cancer. Today, better diagnostics and treatments are changing outcomes, yet there's an urgent reality. Prostate cancer deaths have risen by about 3% each year since 2014, and many men are still diagnosed too late. In the United States, it remains the most common cancer among men and the second leading cause of male cancer deaths after lung cancer. We're here to unpack what's changed, what hasn't, and why awareness matters. Dr. Taneja is Senior Vice President and Northwell System Chair of Urology and Chair of the Smith Institute for Urology, a surgeon whose long career has been spent driving innovation in urologic cancer diagnosis and treatment, especially prostate cancer. He pioneered the use of MRI to diagnose and pinpoint prostate cancer, along with MRI-guided ablative therapies that aim to destroy only the cancerous portion of the prostate. Dr. Taneja, welcome.
Thanks so much for having me.
We're just going to jump right into it and start with the basics. For those unfamiliar, perhaps someone just beginning to learn about prostate cancer, what exactly is prostate cancer and how does it develop?
So I think it's important first to understand what a prostate is. The prostate is a reproductive organ, so it makes enzymes that are critical for fertility. So when men are going through their developmental years, the prostate is where most of the ejaculatory volume comes from, and it liquefies the sperm or the semen so that it can pass through the cervix and fertilize an egg. So because of that, the only function is that. It just happens to be in a tricky spot, perched between the bladder and the urethra, wrapped around the neck of the bladder, and there's a lot of critical structures around it, but it's not really part of the urinary tract. For whatever reason, as men age, the prostate, very similar to the breast in the woman, is susceptible to cancer formation. And if you go back in history, there's reference to prostate cancer back to very early documents, suggesting that it's not a cancer that just arises because of changes in our environment or external, sort of carcinogens that some other cancers like lung cancer are due to. So there clearly is a process of aging that leads to prostate cancer. There clearly is also some relationship with the patient's genetic makeup. Ethnicity influences the risk of prostate cancer. Family history influences the risk of prostate cancer. So prostate cancers form in the prostate as patients age. There's a number of different kinds of prostate cancer. There's slow-growing prostate cancer, which doesn't have the ability to spread and may never harm a patient. But unfortunately, some prostate cancers are quite aggressive and can lead to death if they're not caught and treated early enough.
You mentioned that it can happen as men age, but how do you account for the increasing number of young men now that are diagnosed with prostate cancer?
I think there's clear evidence that younger men are found to have prostate cancer more often than the old days, but I think that's in part because we're looking for it. And so if we look back into the 1940s, 1950s, and the days before we had blood tests or imaging, the only way we really knew a man had prostate cancer is if he developed symptoms, and by then it was quite advanced. So if a man came at age 70 with very advanced prostate cancer, he he may have actually had it since the time he was in his 40s. So we know prostate cancer has arisen at early ages since some time. The difference now is that we have testing that allows us to find it. That's good and bad, right? It's bad because men are finding prostate cancers when they're young and the treatment may disrupt their lives. It's good because we're finding the cancers early and may have more impact on the outcomes of the cancer for the patient.
I was going to ask you, who is most at risk for prostate cancer and why? But it sounds like just about every man is at risk for prostate cancer.
I think there's some truth to the fact that every man is at risk for prostate cancer, but there definitely are populations who are at higher risk.
So who are those populations?
People of African ancestry, African American men, seem to be at about a 60 or 70% higher likelihood of developing prostate cancer over their lifetime. It's interesting that that's probably influenced to some degree by the environment. If we measure rates of prostate cancer in Africa as compared to in the United States among men of African descent, it's going to be higher here. So clearly, it's an additive effect. Underlying genetics that make them susceptible and overlying environmental factors like diets rich in fat or processed foods that may magnify that risk. Men from Northern Europe seem to be at a relatively high risk. Men from Eastern Europe, some men of Ashkenazi Jewish descent seem to be at high risk. So clearly there are genetic factors that make men susceptible to prostate cancer. The other thing is familial history. If a man has a father who was affected by prostate cancer, there's probably about a twofold increased risk. And that familial factor is not always related to one gene. It could be multiple genes. So the more first-degree relatives that are affected, the greater the relative risk. We've now, in recent years, started to understand there are actually gene mutations that families carry that predict a higher rate of prostate cancer and that it may be more aggressive. A lot of those are similar to the genes associated with breast and ovarian cancer. So now when I see a man with consideration for evaluation of prostate cancer, we take the history of whether they have a familial history of prostate cancer, but we also look for familial history of breast, ovarian, other malignancies, and if they have them, then we'll do some genetic screening to try and determine if there's a risk.
So you mentioned before symptoms of prostate cancer. What are some of the symptoms that men come in with? Or do they always come in with symptoms?
In fact, most prostate cancer that we diagnose does not cause any symptoms. All right, so most of the time we're diagnosing it on the basis of a blood test or an exam. The prevalent comment that men will make is, I don't understand how I have prostate cancer, I feel just fine, right? Now, some men do have symptoms, and remember what I told you, that the prostate is located between the bladder and the urethra. It wraps around the neck of the bladder like a donut. So you could imagine if there's an enlarging tumor within the prostate, it may compress the urethra and make it hard for men to urinate. One could be blood in the urine, one could be pain with urination, and if it spreads to other organs, typically bone or lymph nodes, then one may develop symptoms related to that spread, like bone pain or things of that sort.
So when men come in to you and they got the diagnosis of prostate cancer, what are some of the biggest concerns or fears that they share with you?
I think prostate cancer is so talked about. Remember that 1 in 6 men will develop prostate cancer within their lifetime. It's a highly prevalent disease. So there are very few men who are going to walk in the door that didn't know somebody who had prostate cancer, whether it be a brother or a neighbor or an uncle, etc. And that person's experience drives their perception of what prostate cancer is. So they come in with fears. Fears about death from cancer. That's obviously a concern when you hear the word cancer.
Cancer in general.
And fears of the consequences of the treatment. I try to convey very early on is that prostate cancer is not the same in every man. The word cancer is not the same for every cancer, and it's not the same for every prostate cancer. There's some that are slow growing, some that are very fast growing, and the nature of the cancer really dictates what needs to be done about it. Also, that it's not like prostate cancer was in the days of their uncle or their father, because in those days we had limited options and we were dealing with disease that was diagnosed at a much more advanced stage typically. Now, with very early stage cancer detection, it opens the door to different options. We have tremendous advances in technology, tremendous advances in imaging that allows us to characterize cancers. And I work very hard to individualize the care of each patient so that whatever treatment we pick is the best fit for them in terms of giving them effective treatment, but also living up to their expectations and priorities for the rest of their life.
Let's get into, you talked about treatment and individualizing care. Let's talk about some treatments for prostate cancer.
So treatment for prostate cancer can really be divided into 4 broad categories. And I usually counsel men in that way, sort of stepwise. When a man comes in with a newly diagnosed prostate cancer, the first decision is always, do we need to treat it at all? And that's the first management category, doing what we call surveillance. Surveillance just means that we don't think the cancer poses enough of a threat to you right now that you should be subjected to any side effects from treatment. So we'll monitor it, and if it worsens, intervene before we lose control of it. And if it doesn't worsen, continue to monitor it. Since we've developed MRI as a tool for looking at the prostate, it's reduced the invasiveness of the follow-up. When surveillance first came about, it meant biopsying men every year. Since I've used MRI over the last 15 years roughly, I now biopsy men every 5 years in general on surveillance, and we monitor them in between with MRIs. But in my practice, what I advocate is a PSA twice a year, an MRI once a year, and biopsies as needed if the MRI changes, etc. But as of yet, we really have not seen cases where we lose control of the cancer if we're monitoring it closely. So surveillance is a very reasonable option for probably close to half the men that we diagnose with prostate cancer. That's always step one. Part of that decision is who is the patient, right? Because I could diagnose prostate cancer in a very healthy 52-year-old who has an expected longevity of 30 plus years, or I could diagnose it in a 75-year-old who's had 2 heart attacks and a stroke. Those are very different patients. So building that risk model, how bad's the cancer, how healthy is the patient, helps us to figure out the right treatment. If we decide the patient needs treatment, there are 3 categories of treatment we can offer. One is surgical removal of the prostate. One is some form of radiation to treat the prostate. And the newer area of treatment that I've been very interested in for the last 15 years or so is what we call focal treatment. Focal treatment or focal therapy means that rather than treating the whole prostate, if we catch it early and it's localized, we just try to destroy one part of the prostate. We typically do that with thermal energy, heat or freezing energy. And there's a lot of emerging data that for the right men, that can be a way of treating while avoiding some of the potential side effects of the treatment. Surgery treats the whole prostate by removing the whole thing. Radiation treats the whole prostate by destroying the whole thing. And the focal approach is a more selective treatment of just the tumor if we can localize it with our MRI and biopsy.
Now, with all these advancements, is there any likelihood that the cancer may return?
So, yes, of course. Any treatment I offer a patient can fail. It fails for different reasons, of course. If we treat the whole prostate with surgery, as an example, failure would occur if microscopic cells had already spread to other parts of the body but simply were not identified. If we treat with radiation, the same could occur. Outside the area we're radiating, there can be recurrence if cancer spreads occurred. Radiation can also fail if any of the cells in the prostate survive the actual radiation. And focal therapy, of course, can fail if one develops a new tumor in the area of the prostate that's not treated. So failure can unfortunately occur with any of the treatment options, and that's part of the discussion when we diagnose a prostate cancer. If our treatment doesn't work, what will we do as a salvage strategy, as in the case of somebody whose disease comes back a few years after treatment?
We know that Northwell has developed a unique approach, a rapid diagnostic pathway program, I believe it is, for prostate cancer. What is that? How does it work to catch these cancers early?
Very often when men have elevated PSAs, for a variety of reasons, they either don't get referred to the urologist right away, or they have trouble accessing a urologist because of long waits, etc. So the RDP, or Rapid Diagnostic Program, was developed at Northwell with the idea that we would like to see men as early as we can in developing our prostate cancer diagnostic approach. So I think the way it really works is that if a man has a PSA above a certain level, 3 in this case, it gets flagged in their primary care physician's chart, and a request is made to refer them to the RDP program. A nurse coordinator then contacts the patient, finds out their history, if they have an infection or other reasons that their PSA might be elevated, and if not, sets up an MRI for the patient and a follow-up with a urologist for a biopsy if it's needed. The early data, as I'm told, has resulted in a reduction of time from elevated PSA to biopsy from what used to be 69 days down to 33 days. So making those things more rapid, more streamlined, is a great benefit to the patient mentally, beyond the simple aspects of care.
Now, you mentioned something before that I think keeps a lot of men from going to the doctor, getting screened. Men are concerned about their sexual function. Can you just talk a little bit about that?
So it has to be a part of the discussion. I think it's disingenuous when people say don't worry about it, because the treatments we offer, regardless of what the treatments are, they have the potential to affect specifically erectile function. Why is that? The position of the prostate, again, it's located just off the front surface of the rectum, and that's where there's a whole stream of nerves, spiderweb-like nerves, that travel from the penis to the central nervous system and control erections. So if those nerves are cut or traumatized or radiated, there's a potential that a man will lose the ability to have an erection. Remember also that the prostate creates much of the fluid at ejaculation or orgasm. So if a prostate is removed, a man can still have an orgasm, but there'll be no fluid, so it's dry. So it's a change in sexual function. So there has to be a very frank discussion of the potential outcomes with sexual function, regardless of the treatment that's offered. There are a number of treatment options for every man. The nature of the cancer is different, and the nature of the treatment is different.
So finally, Dr. Tanisha, to our men and women listening today, what's your final message to them? What do you want them to know?
I think it's really important for them to know that avoiding testing, avoiding the issue of prostate cancer, puts them in a worse position. It leaves them with fewer options. We understand the disease better now. Not everybody needs their prostate removed, but those who have cancers that are potentially harmful, we want to find them as early as we can and treat them. So don't be afraid of the testing. It's to your benefit. You're always in the driver's seat. You can choose what treatment you want. And if you go to a good doctor who's going to take care of you, they should take the time to explain all those options to you.
Well, thank you so much, Dr. Tanasia. This has been an incredibly informative conversation, and I can't thank you enough for educating our listeners. And to our listeners, until next time, this has been another episode of 20-Minute Health Talk. Again, I'm your host, Sandra Lindsay, and until next time, be well.